excited to welcome today an important topic with two amazing dedicated physicians that have been working on our medical advisory board, Dr. Beth Schwartz and Dr. Monica Lemmon. Welcome to both of you today. And today we're going to be talking about bridging care, and we're going to bring it from the perspective of really talking about that acute care setting. And Dr. Lemmon, your work, talking to families in the NICU as a neurologist, but also, moving into your community practice afterwards. And then Dr. Schwartz, your role as a community physician and pediatrician and caring for kids, across all spectrums of developmental outcomes and things like that. So welcome. And again, thank you both for joining us today. So I gave just a brief who you are, but I'd love to hear your introductions as well. And so whoever would like to start, feel free. So, all right.
Sure.
Sorry.
I knew that was going to happen. Monica, go ahead.
Hi, I'm Monica Lemmon. I am a child neurologist at Duke, and I focus most of my time in fetal and neonatal neurology. And I think first and foremost, I'm just delighted to be here. I just so admire Betsy and more broadly the work of Hope for HIE. It's really, it's been a service to my patients and families, and I'm just grateful for all the work that the community does. And in my own work, I see patients for actually a minority of my time, a deeply loved part of my time. But the majority of my time is actually spent doing research, and that research is on a handful of topics, but the one sort of near and dear to my heart is thinking about how we can better discuss outcome to families in the hospital and as we move forward across a child's life to help families better prepare for the future and make decisions for their child's care. And that's a big sort of motivator and focus of my work that I think intersects with what we'll talk about today.
Wonderful.
I'm Dr. Beth Schwartz, and also thrilled to be here and thrilled to be part of the medical advisory board for Hope for HIE. I am either retired or between jobs at the moment. In addition to my work with Hope for HIE and a couple other things. So that remains to be seen for the moment. We'll blame COVID. Thrilled to be helping out with families understanding what their general pediatrician can do, can't do, and how, and what is a medical home and how does that work?
Wonderful. And I'm just going to give a little bit of context to both of the people that are joining me on stage today. One, I have a personal connection with Dr. Schwartz. She served as my kid's pediatrician. And I feel like we built what I would consider a best practice in patient, family, and physician relationship. And she set high standards for when she retired out of her practice. And helped us transition very nicely to another pediatrician. So we can talk through that as well, because I think that was, for my own experience, something that I've really tried to encourage other families to build as well, to have that, when talking about what would be a good relationship to look like with having a community pediatrician. And I thought that this was like kind of the gold standard. And I think that you set such a good standard for that. And then Monica and I have worked on a few different projects now, and in particular care and communication within that NICU setting. So this is, I know it's her passion in research and in practice. And so I'm really just so thrilled to have this discussion today. So thank you both for your introductions. And so let's just start off with, Monica, your experience of preparing families to discharge out of the NICU and transition care.
Yeah, absolutely. And I'll start by saying I'm far from an expert in this topic. I think the folks who are listening in, right, or who might have lived this or are living this are experts in this topic. And so much of what I describe, if I'm getting any of it wrong, I hope you'll type along or contact me to help me get it right. Something we find a lot in the NICU especially in cases of children with HIE, is that many families will describe that communication is a big challenge, and it's especially a challenge around transitions. Communication is fragmented. It's fragmented in the hospital at baseline, and it's even more fragmented as you're transitioning, maybe, certainly from the NICU to home, but also from, for example, the NICU to what could be a step-down unit or a different type of nursery. Just leaving that core team that you may have built solid relationships with can be a major source of distress. And so something that we think a lot about is how to mitigate some of those challenges. And so what our families, many of our families have described, our communication is fragmented. All of the uncertainty amplifies that distress. Uncertainty about what the future might look like, uncertainty about what life day-to-day is going to look like at home, in a week, much less a month or a year. And just the complexity of all of the information amidst what is largely a traumatic experience for many, I think can amplify what are already existing challenges around transitions. And so as we think about how to do this better in the inpatient setting, things that we are often relying on or leaning into are involving parents in care as much as we can. Certainly COVID has made that more challenging in some ways in daily care, and really as a leader in all aspects of care. The care at the bedside, the conversations with the team, and certainly any decisions that might impact what life looks like at home. And so a key principle in my mind is this idea of partnership and engagement. And that's something that I hope clinicians are providing to families. One message, since the majority of folks listening to this are families, is that it's okay to expect to be involved and empowered in your child's care, and to expect high quality communication even as transitions occur. Many families describe the lack of that longitudinal team can be challenging, and it is okay to request longitudinal help, whether that's a longitudinal bedside nurse who you've developed a relationship with, a longitudinal consultant who you've met early on, who you're like, but as I get closer to discharge, I want to talk to that person again. All of those things are okay to expect and request and ask for. And even though our models of care don't always allow us to meet those needs, I anticipate most clinicians want to do their best. And so helping them see areas where care might be fragmented is one way to hopefully provide additional continuity. And as we get closer to discharge, many families I work with will say, wait a second, once I heard about therapeutic hypothermia, I didn't process all of the information about what the future might look like. And it's okay to have more conversations, to ask the same questions again and again and again. That is expected. It's part of our job to provide that degree of specificity and support. And it's even okay to ask it again in follow-up and again the next visit. Because it may not be until you get home that you remember that, you know what, I never did get a good understanding of how this all fits together with the story of my child's birth. And we want to be there to support you in that. And it's always okay to revisit that really important information as you're transitioning out of the NICU to home and to subsequent providers. It's important and appropriate to ask those questions.
I think that's such a good point. And that's something that we hear a lot. A lot of these questions that sometimes families ask when they're newer in their journey as well in our support forums is, like understanding for us, what is peer-to-peer support and what is something to, ask your physician or care team member, like, hey, I know they talked to us about MRI and things like that, but I don't understand really what this means, and we'll always say, we're not, that's out of our scope, but please be sure to reach out and ask your physician, even if they've already answered it to you once. If you didn't understand it, you need to ask again. And, and it's such a good point, Monica, to bring that up for sure. Yeah. So I think as we move into the next topic, as we transition into different, out of the NICU and into these different clinics, whether it's primary care or specialist care, that, take us through kind of, setting up this primary care and, who's quarterbacking services and how this whole thing works as, people are getting out of this acute care setting and into this slew of appointments that everyone is faced with after that NICU or PICU stay.
So, certainly there's the idea of how we would hope it would work. And communication being absolutely key and bottom line. But it is a huge change. And, you can't always anticipate everything at all. So ideally, as let's say you're being discharged from the NICU, you're heading home, you feel like you're in total limbo there. Ideally, there will be a handoff to a pediatrician who knows not all of the story, but certainly a lot of it. But then, there's every family's own details. Were you told different things by different people? What are your expectations? And how on earth are you going to get to all these different appointments and see all these different people? And knowing that you've got, the idea of the medical home is, you said quarterbacking, somebody to help with coordinating. Do you need all these appointments? Often the answer is yes. But sometimes there's a little redundancy or oh my goodness, those people are all in the same place on every Thursday, every third Thursday. Let's get you in on that time. And being able to keep asking questions. So I think it's keeping communication open on all counts. Ideally, you'll be notified of discharge ahead of time and be planning. And that the NICU team or somebody from them will have ideally called, possibly emailed, shared a chart. The range is huge depending on where you're going and coming from, but enough information that the doc on the receiving end can be somewhat ready. And ideally take some extra time, which doesn't always happen. And sometimes it takes a couple visits to get that all through. Asking questions, anticipating needs, coordinating a lot and helping with that. So how is that communication going to happen? Is it going to be mostly through my chart? You need to get to your doc, the my chart's not picking up, the phone lines aren't working. What do you do? And that's going to vary depending on the doc. The answer is sometimes a personal cell phone, but not always. And you got to know, am I comfortable? And if if somebody gives you the personal cell phone, can you really use it, or are we just giving you the number? What's that for? And if you call and your doc's not on call, you're going to get somebody who can at least access your information. So much communication, but a lot of it is really making sure that people are comfortable asking questions and keeping it going. So that's kind of a general scope of it. Mm-hmm. And one other thing I wanted to make sure that we added was, anticipating that this is huge, that you may need more help. Who's your team? Who's backing you up? What's going on with the family as far as not only backup, but understanding? Are you being asked every single day, what does this mean in the long term, when you absolutely do not know yet? And leading into, do you need some mental health services? And I would wonder, if not, why not? Mm-hmm. So, and really adding as many layers of support as humanly possible.
Monica, did you have any thoughts on this as transitioning into like the specialist clinic?
Yeah, I think all of those are really key ideas. And what I would add is in a perfect model, you've met the person you're going to see. And so you have an established relationship. And in that case, things like my chart are wonderful to communicate small and big issues. Something I really appreciate when my patients send me messages to say, you know, I know we have a meeting next week. I really want to talk about this really big issue. And what a gift that is, so that I can make sure that, you know what, we might need more time than we've actually allotted here. And I can kind of prepare for that conversation. And so especially when there are really big picture things on your mind, for example, what the future might hold, or can you let's go over everything that happened in the NICU. Hopefully your provider is just ready to spend the appropriate amount of time to make that happen. And if you're unsure, a heads up can always be helpful to say, this is, my hope is that we'll address this information at this upcoming visit. And that might help us make the appropriate time to do that. And sometimes that means scheduling more than one visit to address the most important concerns of yours in visit 1, and then to have a follow-up conversation 2 weeks later, or by phone, or these days by telehealth. But that type of preparation can really help us. Now, sometimes the world is imperfect and you'll be following up with someone who you haven't met before, or your child might have been born at a hospital that didn't have a neurologist on staff who you got a chance to meet. And in those situations, there might not be an easy mechanism to contact someone in the in-between time. And I would say that when that happens, of course, your pediatrician is an incredible and key resource. And it is okay to call the office and say, I need to talk with someone in advance of this appointment. And while that may not be a perfect substitute for someone who knows you well, it's a start. And so I think knowing the main message I want to give is, if you're worried about it, we're worried about it. And we want to talk with you. And if sometimes things get in the way of that type of communication, and usually we have ways to work around that, even if it's a phone conversation before a visit, just to talk through an urgent concern, for example.
Yeah, that's such an important point. And I just remember, Max was delivered when I was 37 weeks pregnant. And so we had booked like our pre-baby, birthing class that was set for that following week after he was born. And then we hadn't picked a pediatrician. And so we were like way behind the 8 ball. So, when we got to discharge, they're like, oh, well, who's your pediatrician? And we said, we have no idea. We have, we were going to do that. And he's been here. And then this happened. And what do we do? And for us, we had always planned, I had delivered into the health system I had worked for, and and had always, planned to go through the pediatricians in that health system. So they're like, okay, well, this is the best clinic, and all these docs will be great. Just pick one of them. I'm like, okay, good. We'll go from there. So, at that time, I don't think my chart was rolled out, because now Max is almost 9, but I think quickly after it was, but certainly, I remember that in between time being very scary, and not so much with, pediatrics got us right in because as they typically do within, I think, 24 to 48 hours post-discharge, but definitely waiting for that 3-month neurology appointment was like, because one, you're waiting and seeing for 3 months, and then you're like, is this a concern? Is this not a concern? And just, the trepidation behind that. And to your point, Monica, of saying like, while, you might have met that person, or you might not have in the NICU, that phone call of saying, I'd like to discuss this ahead of time, is such an important point to make. And yeah, just remembering those early days and how scary that was, and how unsettling, but then thinking through how that partnership has been built over the past several years. So, which really takes us into our last topic, which is building that patient and family partnership. So, and we've talked a lot about with our families through, the work, I think our personal experiences, our relationships with both of you on our medical advisory board, trying to encourage our families to find, and identify ways to communicate with each provider on the team and what works best. I know for us, in the health system that we're a part of and in Beth's practice, there was an after hour, there was always an on-call nurse and physician that we could get a hold of. So whether it was Beth or someone else, and certainly I used that several times, that was always very great to have that access. With neurology, I know, showing any videos of concerning anything, and finding a way to get those. While my chart, at least ours, doesn't have a video option, you could work around that by, posting it to an published YouTube link, and then share that link, in the message to get it over there. And we had several of those, concerning movement and things like that we'd get over. And so, yeah, just finding out and being proactive to ask the team, when you don't know what questions to ask. I think asking, being armed with if we need to get a hold of someone and it's after hours or on the weekend or on a holiday, which is when a lot of scary things tend to happen, or always, what is the best way to get a hold of someone, and when should we, do X, Y, and Z, so I guess, let's move into the conversation of what, you want families to know. And then, we can talk through what families want physicians to know as well in this. So about, any tips or strategies of building that, that partnership.
Yeah, I'll start by saying, I think what families want us to know is probably the most important piece. And in general, I hope that most of us are trying to provide pretty individualized communication to families. Something I find helpful, certainly if you have an electronic way of communicating that is helpful. One of the reasons is because that's a place your clinician is going to look. And it's in the record, which is really helpful for everybody. And so it means when you send a message and we're talking about abnormal movements, that other people in the health system can see that too. And then we can also review it, prior to a visit to remember what's happened in the intervening time. And so certainly when electronic health records are available, that's an outstanding way to communicate about issues. Of course, urgent matters should be elevated to an on-call service. And so most clinicians check their, whatever their inbox is, whatever version they have in their system. Some might check it every 24 hours or multiple times a day. Others might have a standard of every 48. Learning from your physician what that looks like can be helpful. And asking the question, how do you want me to reach, if there's an urgent concern that's not a call to 911, but it's also not, I can't wait till the morning, how do I reach someone and who will I reach? And having that ready is super helpful. Almost all practices will have some mechanism for an on-call provider. And that's absolutely something that's important to use for urgent situations. Of course, for non-urgent situations, if they can wait, doing that during daytime hours is not only helpful, but I think promotes better care, because you're more likely to get that team that knows you best if you're able to reach them between typical working hours. And so those are a few key things and key issues that we always want to know about as neurologists include funny movements. We are always really interested in new movements, especially any that might look like something called infantile spasms. I know that Hope has put out a lot of really important information about infantile spasms. But when I think about things that keep me up at night between discharge and sometimes that first visit, is the development of infantile spasms, depending on how long you've got to wait, is something that might, there is in some health systems a chance that you wouldn't have a chance to meet with a neurologist before that. And so if you see a new movement, especially something that clusters and that seems to be associated with a loss of skills of any kind, we think about that like an emergency, something that we really want to know about right away. And just like Betsy suggested, videos help us so much because they can sometimes help us know we need urgent testing, or actually more often help us say, you know what, we actually can watch this and we're not as worried about this. And we love reviewing videos. The worst case for me is that I get to see a really cute video of a baby, and that is an appropriate ask of my time. It's something I love doing. And so we would rather review 100 videos if we could catch one that was some type of new seizure type. And so my main message, I hope, is that you're not bothering folks when you're asking questions. If you're worried about your child, so are we. And using videos, especially for movements or things that you want a neurologist to be able to speak to, can really help us move things forward.
So I'll second that as the pediatrician spokesperson, that if something has you concerned, it has us concerned. If we don't have the answer, we will help you find it if there is one. So, we're talking about that gap between visits with various specialists. Let's say you're not seeing the neurologist for 3 months, which might be unusual, might not, depends what's going on, but something may come up in between there. And not only, can your pediatrician help triage a little bit, how worrisome is this, but also, like I said, I may not have the answer, but we can help you find it, and call the neurologist and say, you need to see this kid. So there's a lot of that in various different ways. It's unusual that somebody would get discharged without the correct referrals, but they may be missing one or two, just what you need, even more, but that can also happen. So more and more communication.
Yeah, that's so helpful. And so I know one of the other things that we wanted to talk about is, connecting to early intervention services and kind of talking through therapy referrals as well. And I know, Beth, you helped us with a lot of those things early on as well. And then just, as things kind of went through and we might need to add a specialist or look at, a referral here or there, when to engage and talk with your pediatrician about, what is going on and where those community needs might be able to be fulfilled.
And, you're talking to other parents, other families, hey, this guy's going to go see this person, or an alternative therapy. Does this make any sense for us? Is this something to look into? And especially in a timely manner, have we missed something? And occasionally, do we have too many? Is there a way to simplify things at all? But very key. And being able to feel comfortable asking questions. And, continuing with, is this okay? I have this question. What do you think of this? What do you think of this? Key importance.
Yeah, that's definitely helpful. So any other, I think the last thing we have is really just talking about building your team. And if there's any other thoughts on, how we move forward doing so in the journey of, all of what our families go through. And I know we've added specialists in our case and taken them off at different points in time and just kind of, gone through this whole journey. I know a lot of families are in similar situations. So I guess just any final thoughts that you might have and that you want families to be aware of.
Yeah.
Good.
I would just add that I think we recognize this is a team sport, and I think one more transition that often happens is transitioning from different types of specialists. Sometimes, many children need neurologists long term. Others need different types of neurologists long term, and some patients need more specialists over time. Others need less. And I think key is a longitudinal trusted relationship with your pediatrician, which I'll certainly let Dr. Schwartz talk to more, but also asking, what's the time horizon look like? When and who might I meet? Who else should be on this team? I just want to echo something Dr. Schwartz said, that sometimes you have too many people on your team. And if that's something you're feeling, it is okay to ask, how do I prioritize? We all know that therapy is just the backbone of what many children need. And we know that much of it is delivered by parents. And so thinking about how to leverage that to decrease your number of appointments without actually reducing the hands-on care your child's receiving kind of as much as you might think, are sort of creative ways to try to simplify. But I guess I would just say, in general, I think we all deeply believe that children thrive when their family is also thriving. And if the care team is becoming a burden and not kind of a facilitator to you thriving, that's a good time to take stock and take a step back and say, how can we make this work for our family? And I hope that we can all help you do that. But that's an okay thing to feel and to ask.
Which it sort of brings up in my mind another transition as the kiddos are being introduced to the school system. And I think, if I remember correctly, this happened with Betsy and family and Max, where there was some redundancy and then there was some gaps. And at one point you have to say, wait, I understand this is all well-intentioned, but let's sit and really think about what are we doing? And there's only so many hours in a day to do so much. And I've had other families also say, you know what? I need a break from something. It's just not fitting. It's not happening. And that's really important. And it's really important to feel comfortable saying that. That, admitting, you know what, I haven't done this in a week because I don't have time. And it seems a lot like something else I'm doing. Let's talk. And that's really important.
Yeah, I think you were one that encouraged us to take breaks as well, because we were, I remember this kind of sentinel moment being, Max was around 18 months and we were just all burned out, and it was like, everyone was encouraging us to take a break. You were encouraging us, our therapists were encouraging us, and it was the best thing for our family. We just could not, I think it's very easy to get into this, therapy at all costs mentality. But really you can't, it's like the whole oxygen mask conversation of you need to put yours on first before helping others, but really you all need it at the same time too. So making sure that you take that break. And then, really the point that you brought up about the school system. I know we worked with you in several different cases in those different transitions, 0 to 3, 3 to 5, K through 12. And, having different like working together on different letters of what Max's needs would be and what would be best for his individual development. Mm-hmm. And I believe there were a couple of times that, we worked together on those. And that was just so important because we do sometimes have that disconnect between the medical needs and educational system, and then finding what, where we can come back together. And a lot of times, in order to best get what our kids need in that educational setting, you do need the medical backing for that. So that was definitely something important for us as we had gone through all those transitions. Now, he's in 3rd grade, so things are a little bit more, we've been in a good groove for several years, but those transition points were absolutely difficult. And you were such an excellent partner to work with through those to make it, much easier and make sure everyone was on the same page for where his needs were and how to make them and help him progress. So I think that's another great point to think about of how you can work with your pediatrician and whole medical team.
I'll continue this love fest. You made it easy. But, your pediatricians can call schools and talk to them. You may have to nudge them a lot to get them to do it. But it can make a huge difference. So that same aspect of care coordination with schools, with, who knows, summer camps, with virtual learning, I can only imagine. So if, just ask, keep asking. So.
Yeah, it's amazing how, and again, and it's factually accurate, but like, it's amazing how a letter from a medical, team member can impact and help you a lot of times advocate for your child's needs in that educational setting, for sure. So that was, I know, a big one. We had a letter from you, we had a letter from our neurologist, like all the things. So, and it all worked out very well. So, which was great. And I think just to touch on the point of when we transition out, and this could be for any specialty in any case, because team members do change. I think that the best practice situation of, your retirement and you saying, yeah, you need to look for these different things, and these are the people that I would recommend, and this is why, has been such a good study, because I know that doesn't happen all the time, but in other situations. But we were very lucky in that we kind of had these expectations of the relationship that we had built that we wanted to carry forward, because things pop up, as we know. And how can we continue those things and make sure that we have that good communication. So for us, it was really important that we had someone that'd be responsive on my chart, that would have that continued after hour care, that would have that continued good communication after you had built these good shoes to fill. And again, that can be said of any specialist and any team member, and making sure that your expectations, you're allowed to have those, and having your other teammates, when we talk about, this month's whole theme is called Team Hope. It's really about that teamwork and everyone working together, finding and making sure that that those needs are met, because they're important, and it does impact, everyone's well-being. So, and really the child overall as well. Great. Well, any final thoughts from anyone? I think that was pretty amazing. I think there's a lot of things that people can take out of this, and I just appreciate both of you so much for taking the time to share your expertise and your experiences working with families, and serving on our medical advisory board, and doing all the great work that you do, out there in the world, for so many people. So thank you again, both of you, so much for all you do.
Thank you.
And thank you everyone who's been joining us today.
Thank you. It's really a joy to be here.
All right.
Thank you.
Well, take care, everyone.
All right.